Okay, thank you, dear Nagla.
Thank you, Dr. Aliaa.
Thank you, Dr. Nagla, for a very fantastic presentation for today's webinar. The third presentation, I'm proud to present Dr. Aliaa. Dr. Aliaa is a professor of endocrinology in Alexandria University. She is the president of Alexandria Thyroid Association, and she is going to address the topic of treatment or management of Graves' disease during pregnancy. So go ahead, Dr. Aliaa.
Thank you, dear Tamer. So my lecture today is about the management of Graves' disease during pregnancy. It really is a challenging issue. First of all, the Graves' disease is the most common cause of clinically significant hyperthyroidism in pregnancy. It involves risk to the mother, fetus, and neonates that are related to both the disease itself and its treatment. It flares at around 10 to 15 weeks of gestation and remit in the late pregnancy, but often it recurs. First of all, as you all know, that the pregnancy has an impact on the thyroid function and its morphology. These thyroid hormones, the TSH level, is physiologically decreased during the first trimester due to elevation of the thyroid hormone secondary to follicular cell TSH receptor stimulation by the human chorionic gonadotrophin. The reduction begins in the 5th or the 7th weeks of gestation and reaching a minimum between the week 11 and 12. But during the 2nd and 3rd trimesters, the TH level progressively increased, but it is within the normal range. Regarding the free T4 immunoassay is hampered in pregnancy by the increased thyroxine binding globulin concentration and reduced albuminemia, and as variation in protein concentration can impact the immunoassay, the reduction in free T4 is classically found during the 2nd and 3rd trimester. And these are the changes that occur frequently in pregnancy and their impact. First, we have the increase in the circulating human chorionic gonadotrophin that lead to raising in the free T4 and TSH suppression. And we have also increase in the synthesis of thyroxine binding globulin that leads to raised total T3 and T4, the increase in urinary iodine excretion that lead to increased iodine requirement, and activation of placental deiodinase 3 that lead to peripheral T4 and T3 degranulation, and immunological problems that lead to decreased thyroid antibody levels. And as we see in these graphs, these summarize what happens in pregnancy regarding the thyroid hormone. As you see, there is increase in the thyroxine binding globulin, association of increase in the total T4. On the other hand, the increase in the free T4 and the reduction in the TSH due to the elevation of the human chorionic gonadotrophin. And also in the first few months, the fetal is dependent on his maternal thyroxine. After about the weeks 11, he began to have his fetal thyroid hormone production. And also the iodine clearance and the degradation of the T4 by the placental 3 deiodinase are also increased during the last weeks of pregnancy. Thus, the thyroid hormone profile during the first trimester of pregnancy resembling the hyperthyroidism. So how can we diagnose the Graves' disease during this period? The diagnosis of hyperthyroidism is the same during or not during pregnancy, although the clinical signs typical of the first trimester, such as the fatigue, the nausea, and weight loss, should be distinguished from those of thyrotoxicosis. First of all, we should recommend the TSH assay is the first line to be examined for the positive diagnosis. If the TSH is suppressed, we order the free T4. And then if this we should have a trimester-specific range for the TSH to reach the correct diagnosis. The ordering the free T4 is to assess the biological severity of hyperthyroidism. The etiological diagnosis of Graves' disease become clear and straightforward by the history of Graves' disease, whether cured or not, or the patient is under treatment before the conception. This makes the diagnosis easier. Also, the presence of thrilling goiter or signs of Graves' orthopathy have an impact for helping us to diagnose that the patient have a Graves' disease. Goiter also should be distinguished from the physiological increase in thyroid volume during pregnancy by the presence of the thrill. The anti-TSH receptor antibodies usually confirm the diagnosis, and its absence suggests that these pregnant ladies have what is known as transient gestational hyperthyroidism. The presence of the TSH receptor antibodies also assess the risk of transplantal hyperthyroidism. In case of diagnostic uncertainty, we may have to do the Doppler ultrasound, which can explore the goiter or the hypervascularized thyroid that make Graves' disease is of priority. But it should be stressed that this examination does not feature in the American or European guidelines and has not been shown to discriminate between Graves' disease and other form of hyperthyroidism during pregnancy. On the other hand, the iodine 123 or technetium 99 is contraindicated during pregnancy. And what about the differential diagnosis of Graves' disease? The first important thing that should be distinguished from Graves' disease during pregnancy is what is known as transient gestational hyperthyroidism. And transient gestational hyperthyroidism have a rate of 1 to 3% of pregnancies. That means that it is higher rate than Graves' disease. It is secondary to the thyroid stimulating effect of human chorionic gonadotropin in the first trimester. The concentration of human chorionic gonadotropin are associated with low TSH and 80% of the cases with elevated free T4, and the suggested mechanisms are include the increased quantity of human chorionic gonadotropin as found in single or multiple pregnancies, or in case of high DT4 more and choriocarcinoma, the prolonged human chorionic gonadotropin elevation, and the human gonadotropin hypersensitivity as in exceptional cases of TSH receptor mutation. And we will hear from my dear colleagues, Professor Tamer Sherbini, what we should know about this phase in pregnancy. It is often clinically difficult to distinguish between the transient gestational hyperthyroidism and the Graves' disease, but the anti-TSH receptor antibody assay is recommended to help us. And also we have two other assays. They are just suggested in some guidelines. The first one is the lower human chorionic gonadotropin and the higher free T3 to free T4 ratio, which favor the presence of Graves' disease, or the higher erythrocyte zinc concentration, which favor the presence of TGH. And however, these data are not robust enough to found a recommendation. The second important one to be differentiated from Graves' disease is the hyperemesis gravidarum that was reported in two-thirds of the studies to be associated with low TSH and the higher free T4 levels. But we should know that the American College of Gynecologists and Obstetricians does not recommend assessing thyroid function in hyperemesis gravidarum in the absence of other signs of hyperthyroidism, while the other societies recommend thyroid hormone assessment and anti-TSH receptor antibody assays. The third one is the toxic nodule or the toxic multinodular goiter. They are rare cause of hyperthyroidism during pregnancy. The diagnosis is based on the hot aspect on scintigraphy. But as we all know that this cannot be performed during pregnancy. So the Doppler ultrasound may help us, has not been assessed to diagnose toxic nodules in pregnancy, but can contribute to the differential diagnosis. Really, there are, in fact, no specific guidelines for the exploration of these pathologies during pregnancy, which is performed as outside pregnancy, except for the contraindication for scintigraphy. The other causes of hyperthyroidism, like Deucravain subacute thyroiditis and Hashimoto thyroiditis and fastidious hormone intake, all these should be considered in the absence of the other etiologies. These are the fourth cause of the hyperthyroidism during pregnancy that should be differentiated from Graves' disease. And now, what are the aspects concerning the mother? The aspect concerning the mother come first by the complication that may occur during pregnancy. The complication that may occur either from the disease itself to the mother or to the fetus or by the using of the treatment. There is increased risk of preeclampsia, heart failure, or risk of premature labor. The well-conducted treatment, as we all know, of hyperthyroidism reduce the risk of maternal complication. But I should stress on a very important point that subclinical hyperthyroidism, it is not indicated to be treated during pregnancy because no maternal impact affecting pregnancy by the presence of subclinical hyperthyroidism, and this is very important point. And now, what we should give for the pregnant lady to treat her problem. The two families of the antithyroid molecules on the market, the imidazole and Cyracil derivative, are comparable in their control of maternal hyperthyroidism, and they are comparable also to the time to recovery of euthyroid state. They are identical in this point also. Although it was suggested that propyl Cyracil cross the placental barrier less than the imidazole molecule. Also, I should stress that the combined or block replace treatment is contraindicated in pregnancy. This treatment in which some physicians use thyroxine in association with the antithyroid medication. Because the proportion of thyroxine crossing the placenta is very low. So this combined or block replace treatment is contraindicated during pregnancy. Also, the Cyracil derivative is preferred to imidazole derivatives for Graves' disease in pregnant patients, as latter being considered potentially teratogenic. However, the recent studies suggest that the propyl Cyracil could also cause fetal malformation. Moreover, it induced rare but severe form of cytolytic hepatitis that led to FDA safety warning on this drug. In 2012, the Endocrine Society recommended the propyl Cyracil during the first trimester and switching to an imidazole derivative for the second and third trimester. But recently, it is recommended stopping antithyroid drugs when possible at the beginning of pregnancy, between weeks 6 and 10, under close monitoring of the biological parameters. In case of non-controlled hyperthyroidism or recurrence at the end of the treatment, it is suggested that propyl Cyracil is to be used during the first trimester. But I should stress that this strategy runs a risk of recurrence of hyperthyroidism, and that consequence for the mother and fetus have not as yet been assessed in any studies. The iodine 131 is contraindicated during pregnancy. regarding the surgery is reserved for serious allergy to the antithyroid drugs and to poor control of maternal hyperthyroidism. It should be preferably performed during the second trimester. And now, how can we monitor the treatment during pregnancy? The aim of the treatment is to correct the symptoms of thyrotoxicosis and prevent maternal and fetal complications. The antithyroid treatment should be indicated at 50 to 150 milligram daily for propyl Cyracil, and from 5 to 10 milligram for Cymizole, and from 5 to 15 milligram for Carbimazole. Thyroid assessment should be closely monitored 2 weeks after initiation, then every 2 to 4 weeks throughout pregnancy, or for as long as the antithyroid treatment is continued. The umbilical and maternal free T4 concentration seem to be correlated at the end of the pregnancy. They should be identical when antithyroid treatment was stopped during pregnancy, but with lower umbilical level between when the treatment was continued until delivery. Therefore, the optimal dose is the dose that maintains maternal free T4 in or just above the upper range of the normal, as established in the non-pregnant population. And I should stress also that the TSH level may remain low throughout pregnancy, in which case they cannot guide dose adaptation. The immunomodulation accompanying pregnancy lead to improvement in the hyperthyroidism during the second trimester with apparent remission of Graves' disease. Therefore, when doses has been reduced and the minimal dose maintain maternal clinical euthyroid state with normalized free T4 concentration on 2 successive assays, treatment termination may be considered. And now for the progression, the controlling of the progression after pregnancy. As we all know, in the postpartum period, the immune rebound may induce onset or recurrence of Graves' disease. And this need to be distinguished from the hyperthyroid phase of the postpartum autoimmune thyroiditis, as my friend, dear Nagla, said. In women of the childbearing age, the onset of Graves' disease in the postpartum period occur in 40% of the cases. The anti-TSH receptor antibody and the antimicrosomal antibodies at the beginning of the pregnancy in euthyroid subject are predictive of the postpartum Graves' disease. So when we do these antibodies and they found them higher and the patient is euthyroid, we should put an eye on this patient because she may start to have postpartum Graves' disease in the postpartum period. In case of difficult diagnosis, the third generation anti-TSH receptor antibody assay shows excellent sensitivity and negative predictive value in differentiating Graves' disease from postpartum thyrotoxicosis. If scintigraphy is to be performed, the tracer should be technetium-99 or iodine-123, which have relatively short half-life, allowing breastfeeding after a period in which breast milk is discarded. So the patient can regain its breastfeeding rapidly than the other types of iodine. Recurrence of Graves-related hyperthyroidism may require resumption of the antithyroid treatment, which leaves the question of breastfeeding. The pharmacokinetics of propyl Cyracil, as propyl Cyracil has a short half-life, strong binding to the plasma proteins, and low liposolubility, entails less passage into the breast milk than with imidazole derivatives. In breastfeeding women, propyl Cyracil has no impact on the baby's thyroid status except at the highest dose, which is 750 milligram per day. So at a doses lower than these, breastfeeding for a mother taking propyl Cyracil is safe. Thus, propyl Cyracil used is preferred to imidazole derivative during breastfeeding. Even so, the most recent American guidelines indicate that both propyl Cyracil and imidazole can be administered during lactation, as my colleague Nagla said. The clinical data regarding the Cyracil breast milk are sparse, but suggest no harmful impact on the physical and the intellectual development or thyroid status of the children breastfed by the mothers treated with Cyracil, even in case of iatrogenic hypothyroidism. So according to this, we can use the 3 groups of medications. And then how to prepare our patients that needs to be pregnant. The pregnancy project of women under treatment of Graves' disease need to be discussed. It's worth discussing radical treatment by radioactive iodine or thyroidectomy, especially in situations at high risk of transplacental dysthyroidism. And these situations include the anti-TSH receptor antibody elevation, especially if the stimulatory activity is strong, the necessity of high antithyroid dose, the history of fetal dysthyroidism in previous pregnancy. The radical radioiodine treatment contraindicates pregnancy during the following 6 months and may also exacerbate the thyroid autoimmunity and induce anti-TSH receptor elevation. And these anti-TSH receptors will also take longer time to disappear after isotopic than surgical treatment. Thus, in case of pregnancy project, radioiodine is not the first treatment choice. The other choice is to postpone pregnancy until the antibodies, the TSH receptor antibodies, become negative, is another option that we should discuss with our patient. So all this information should be discussed individually with the patient to enable an informed decision according to the risk-benefit ratio, which partially depends on how long she is prepared to wait before becoming pregnancy. And now we come for the aspect concerning the child. We have certain risk factors that may be present during the follow-up of this child. The first is the hyperthyroidism in Graves' disease diagnosed during pregnancy. The second is the Graves' disease patient under the antithyroid treatment during pregnancy. The third is the euthyroid patient under the antithyroid treatment with residual anti-TSH receptor antibody. And finally, the personal history of surgical or radioiodine ablative treatment, which may lead to the anti-TSH receptor antibody being overlooked or persisting. The fetal and neonatal hyperthyroidism is rare and it is usually transient and affects 1 to 2% of neonates born to the mother with Graves' disease. In normal, the fetal thyroids are sensitized after 10 to 12 weeks, and the TSH receptor become functional around 20 weeks, enabling the fetal thyroid stimulation by the TSH and also by the maternal anti-TSH receptor antibodies. The anti-TSH receptor antibodies impact depend on the balance between their inhibitory action and the stimulatory action of the thyroid stimulating immunoglobulins. The antithyroid drugs may also cross the placenta, inducing the fetal dysthyroidism, while the maternal TSH does not cross the placenta, unlike the free T4 and free T3. The cases of congenital hypothyroidism implicate transfer of thyroid-stimulating immunoglobulin from the mother to the fetus. So in a patient with Graves' disease, the fetus may have a hyperthyroidism or a hypothyroidism. In practice, only the anti-TSH receptor antibodies are routinely assayed, which is sufficient to identify women whose fetus is at risk of fetal or neonatal dysthyroidism. We have, regarding the treatment modality, in a fetus proven to have hypothyroidism, Reducing the maternal antithyroid drugs dose should be enough to normalize the fetal thyroid function, while intraamniotic administration of levothyroxine has been reported. The levothyroxine injected into the amniotic fluid is taken up by the fetus, restoring the euthyroid status and also avoid the progression of a goiter that would compromise a natural delivery. The fetal hyperthyroidism treatment is via fetal treatment by the maternal antithyroid therapy that improved the fetal and neonatal progression. Regarding the neonatal and postpartum follow-up, the neonatal assessment, there is no risk of neonatal hyperthyroidism when maternal anti-TSH receptor antibody were negative throughout pregnancy, with or without antithyroid drug treatment. The major risks are the heart failure, the liver dysfunction, the coagulopathy, pulmonary hypertension, craniostenosis, and microcephaly or mental retardation. If the mother is under the antithyroid drugs, transient neonatal hyperthyroidism may be delayed, with the onset at 10 days of life, as most neonates are usually initially asymptomatic, although there may be increased excitability, appetite with insufficient weight gain, vomiting or diarrhea, fever and sweats, or erythema. Tachypnea may occur in cases of heart failure or pulmonary hypertension. The sinus tachycardia is frequent, sometimes associated with arrhythmia, but rarely with high blood pressure. The clinical goiter is found in 50% of the cases. The umbilical blood thyroid hormone level at birth are not predictive of neonatal hyperthyroidism. The anti-TSH receptor antibody, if higher than 2 international units per liter in the umbilical blood, identify the neonate at risk to hyperthyroidism, and about 1/3 of whom will require treatment. The rapid increase in the T4 levels beyond the upper normal limit for age between umbilical blood assay and 3 days postnatal is predictive of neonatal hyperthyroidism. The clinical signs appear later than the biological signs, and the carbimazole treatment should be initiated on the onset of the later, usually at a dose of 0.5 milligram per kilogram per day initially, associated to propranolol in cases of poorly tolerated tachycardia. This appearance of the anti-TSH receptor antibodies indicate cure and the possible termination of treatment. So my conclusion, the indication for the measurement of the TSH receptor antibody during pregnancy in the first and second trimester, the previous radioactive iodine or thyrectomy for Graves' disease, female with new onset thyrotoxicosis to differentiate Graves' disease from gestational thyrotoxicosis, the previous pregnancy complicated by fetal or neonatal hyperthyroidism, and during the third trimester, women requiring antithyroid drugs treatment for Graves' disease. If the anti-TSH receptor antibody are absent up to the third trimester and no antithyroid drugs are needed, no specific neonatal monitoring is required. If anti-TSH receptor antibody level exceeds 5 international units per liter in the second trimester, there is a risk factor for fetal and neonatal hyperthyroidism. The goiter is the most effective sign of fetal dysthyroidism and can be detected by standardized ultrasound measurement according to gestational age. The fetal hyperthyroidism can be suspected in cases of advanced bone maturation, thyroid hypertrophy with central vascularization, retarded intrauterine growth with fetal tachycardia. On the other hand, the hypothyroidism can be suspected in cases of retarded bone maturation and excessive active fetal movement, goiter with peripheral hyper signal on Doppler, and excess amniotic fluids. My take-home message is the neonatal thyroid dysfunction is usually preceded by fetal thyroid dysfunction, that good treatment during pregnancy is essential to avoid premature mortality and long-term neurological sequence, and thank you.
Thank you, Dr. Aliaa, for an outstanding presentation. As you can see, the three presentations are more or less entangled. So Dr. Aliaa has touched some of the postpartum care. And I'm going to stress once more about the gestational hyperthyroidism. So the three presentations are more or less entangled in the hope that there will be no more confusion regarding the management of thyrotoxicosis, whether this is during pregnancy or in the postpartum period. So we are going to take questions for Dr. Aliaa. Okay, so the first question would be if antithyroid peroxidase antibodies is elevated in a woman who is 5 weeks pregnant with history of 2 miscarriages before, what would be the ideal treatment?
If the antibodies are positive, you should start the Propyl Cyracil. It is more safe, and all the guidelines recommend it in the first trimester. After the second and third trimester, you can shift to the carbimazole in the lower dose. And if the patient is become negative for this antibody, you can stop the treatment and you follow the patient closely.
The second question would be, what are trimester-specific TSH ranges? And this is one question. And the second question would be, when to start antithyroid drugs in hyperthyroidism with pregnancy?
Okay, the trimester-specific TSH range in the first trimester is up to 2.5, second up to 3, and third up to 3.5. And what is the second question, dear Tamer?
When to start antithyroid drugs in hyperthyroidism with pregnancy?
If the patient has a clinical signs, if the antibodies are positive, if the TSH is suppressed and the free T4 is elevated, you can start. But as the guideline mentioned, it is better to start with the Propyl Cyracil during the first trimester, and then the methimazole or the carbimazole during the second and third trimester. But actually, we don't have here in Egypt except the carbimazole.
Once more, is the Propranolol safe in all trimesters of pregnancy?
Yes, it's safe, but it is better to use the calcium channel blocker during the first trimester. For myself, I use the calcium channel blockers in all pregnancy, especially during the first trimester, in spite of the propranolol. But it is, as my colleague said, it is safe. But the more safer is the calcium channel blocker.
Another question, what is the definition of subclinical hyperthyroidism?
The definition of subclinical hyperthyroidism is a suppression of the TSH with normal free T3 and free T4 that we always found during the first trimester. The patient come from the gynecologist with suppressed the TSH and with normal free hormones. This means that this patient has subclinical hyperthyroidism, and this has no impact on the maternal and the fetus, and that's why we don't treat this condition.
Another question from our dear colleague Marzu. He thanks you for the elegant presentation, and he's asking if TRABS is positive with low TSH, but normal free T3 and free T4, and this is in the first trimester. Just for follow-up?
Yes, you can follow up, dear Marzu, but close follow-up, because if the free T4 is increased due to the presence of the antibodies, you should start treatment.
Professor Negwa Lasheen is asking a woman who has been given radioactive iodine to treat hyperthyroidism, after how many years she can prepare to be pregnant?
No, it's first of all, I wanted to appreciate the presence of my dear Professor Negwa Lasheen. It's an honor for us, your presence. And then the use of radioactive iodine, we can postpone pregnancy up to 6 months. And it is better to use the iodine 123 if the patient is lactating. But if the patient is prepared for pregnancy, she can use either the technetium or the 131 and wait for 6 months.
Okay, one last question because we are running out of time. euthyroid positive anti-TBO with recurrent miscarriages. Anything to reduce the risk of miscarriages?
To reduce the risk of miscarriage is the follow-up. First of all, you should do the thyroid function to check for the presence of the overt hyperthyroidism. And then there is no role for the steroids. And the last choice is to follow up these patients up to 6 months until the disappearance of the antibody. But we don't have any things to decrease the risk of miscarriage if the antibodies is present and the patient is euthyroid.
There are small studies that mention that just giving levothyroxine, if there is an indication to give levothyroxine, actually decreases the risk of miscarriage in the future pregnancies.
Even if the patient is euthyroid?
No. If there is an indication to give levothyroxine.
Yes. Because I hear that the patient is euthyroid. Yes.
Yes, but we may consider giving this if TSH is higher than 2.5. Yes. Some guidelines recommend considering this for patients with recurrent pregnancy loss.
Thank you, Tim.